Visible?
Yes, sir, visible, sir.
Okay, so hydrocephalus and anesthesia. These are all the points that you have to remember in this particular case scenario when you go for exam. You must know the definition. You can be asked about the CSF physiology. What is how is it formed? Where is it formed? How does it circulate? What are the functions of CSF? So question can be mainly on that, or they can
Yes,
ask
sir.
you about blood-brain barrier. They can ask you currently about cerebral blood flow regulation and how hydrocephalus is classified, and clinical features according to age and time of presentation, what investigations are needed, treatment options. In this investigation, suddenly they can say this child is posted for an MRI. How will you manage the anesthesia and MRI? That also can be. We discussed it in the I think earlier classes, so I
Yes, sir.
won't go into that. So you have to be prepared for that. Treatment options, what type of surgery or medical management, what are the complications if this is not treated in time, and what is the prognosis. So these are the points that you have to keep in mind. And in this thing, hydrocephalus is a condition characterized by abnormal accumulation of CSF within the ventricles, causing ventricles to enlarge and pressure inside the head to increase. That is the definition of hydrocephalus. So it is classified as functional, pathological, age-wise, and clinical presentation. The functional, it can be communicating, non-communicating, and it can, both of them can be either a congenital origin or acquired origin. Pathological, it is usually the congenital malformations or acquired due to trauma, tumor, or infection. And age-wise, it can be pediatric or juvenile or adult. And clinical, it can be acute or chronic high pressure, normal pressure, arrested hydrocephalus or ex vacuo hydrocephalus. These are the four categories. Of this, the acute hydrocephalus is the one which can result in neurological changes also. Whereas in chronic high pressure, it usually gets some adaptive measures, and the neurological changes are much less compared to the acute change. And what changes happen in the head of an infant developing hydrocephalus in a sequential order. So the bulging pulsatile fontanelles, that will be the first thing. Compared to a normal child, normally you can feel the pulsations in any child during the before the 18 weeks of 18 months of age. But here it starts bulging and there is a pulsation in the fontanelles. Then the pulsation stops. It becomes non-pulsatile and becomes tense. That means that is the time fluid accumulation is increasing and the pulsations are obliterated. Then there is a dilatation of the scalp veins. Then there are separation of suture lines and there is a cracked pot sound on percussion. All these things happen in a sequential manner. And sunset sign is the ophthalmological phenomena where the eyes appear driven downward bilaterally, and inferior part of the pupil is often covered by the lower lid, creating a sunset appearance, just like this. So you can see this. Imagine this is the pupil, and this is the lower eyelid. That is how the covering happens, and the sclera is visible. Okay, so this much of scleral visibility will be there. What is the average head circumference of chest circumference of a newborn? Is the chest equal or low or higher than the head circumference in the newborn?
In a newborn, head circumference will be greater than the chest circumference.
Chest circumference. So head circumference is about 34 to 35 and chest circumference is 2 centimeter less than the head circumference. This is the normal average size in a normal healthy newborn. And what is Evans index and how it is calculated? What is its importance?
Evans index is the diameter of the frontal horn ventricle, sir, and then divided by the diameter of the biparietal index. If it is greater than 50%, it gets hydrocephalus.
Which one you calculate that? Is it in X-ray, CT, MRI? Which one you do?
With MRI brains.
The CT brain.
CT or
Okay.
MR.
The
Yes,
events
sir.
is calculated from CT image by dividing maximum width of the frontal horns of the lateral ventricles by the maximum inner diameter of the skull at the same level. It is not biparietal, it's at the same level. More than 50, it is something like a cardiothoracic ratio in your chest X-ray, where you try to assess the cardiomegaly by taking the transverse diameter of the thorax and the transverse diameter of the heart shadow. Similar to that, this is the Evans index. And so this is the picture that you can see here. This is the lateral ventricle, and actually it should be, this line should be close to this, not so much down here. And there is a next thing called alveoli. What is alveoli? Heard of that?
No, sir. Ventricular.
Anybody else who can say the expansion for alveoli? Right. This is called the anteroposterior diameter of the lateral ventricle index. Okay, that is the acronym for alveoli is anteroposterior diameter of the lateral ventricle index. So here you take the transverse diameter, you take the anteroposterior diameter of the ventricle and the skull and divide that. This is more important in normal pressure hydrocephalus. Evans index is more indicated in high pressure hydrocephalus, whereas alveoli is more indicated quantitative measure of normal pressure hydrocephalus. And what are the surgical treatment for that? We have three options: choroid plexotomy, endoscopic thyroid ventriculostomy, shunts between the ventricle and other body cavities, all the cavities that they have been described. And what is the basis of drug therapy in hydrocephalus, and why drug history is important for anesthesia? You said about anticonvulsant, but
Yes,
is there any drug
diuretics
therapy?
also. Acetazolamide, diuretics.
Diuretic and acetazolamide, both furosemide and acetazolamide have been prepared. What is the basis of treating that?
Sir, to bring down the cerebral edema. If there is cerebral edema,
No,
and
we
it
want
will
that
also
effect.
decrease the
We want to
ICP.
reduce the volume.
ICP.
Isn't it? But
Yes,
what made them think of using these two drugs in this condition? Is there any other tissue or any organ which responds to these drugs in our body?
so we usually do for kidney
Eyes
patients will use.
Eyes and kidneys.
Kidney, so this is the renal usage, the choroid plexus secreting CSF has many ion pumps and enzymes similar to renal tubular epithelium. Okay, so hence drugs like acetazolamide and furosemide are used to limit the production and promote excretion of CSF. That is the basis of using these drugs. So as these drugs cause dehydration and electrolyte imbalance, if the patient has been treated with this drug, it is important to know this drug history and check the status of hydration as well as electrolyte status before you take up the patient for surgery. Can spinal tap be done for all types of hydrocephalus to remove the pressure on CSF?
No, sir. There will be ankle herniation, sir. For communicating, we can't do spinal tapping, sir.
Communicating, you can't do.
Space
indicated only in communicating type. It's not
okay,
indicated in non-communicating.
Non-communicating,
type.
Yes.
So spinal tap is indicated only in communicating type. It's the other way around, not the.
Okay, yes.
Okay. So preoperative management, establish rapport with the patient. Not because this patient we cannot establish rapport, so we have to go for parents. Review the patient and laboratory investigations, optimize conditions like dehydration, electrolyte imbalance, anemia, and infection. Look for coexisting congenital anomalies. All diseases of congenital origin, you must always look for other anomalies. It's associated with Down syndrome. It may have implications for laryngoscopy and intubation. What is the implication in Down syndrome?
Large tongue will macroglossia, sir. So that will.
That is the problem.
Atlantic
It is a vertebral
occipital
problem.
joint
Okay?
yes, sir,
Atlant
subluxation.
joint dislocation is very common
sir.
in Down syndrome. So that is the more important thing that you have to. And history should include symptoms suggestive of raised ICP, such as seizure, vomiting, or neurological, and history of a usage of anticonvulsants. Any seizure that has been present, treated, and history of previous surgeries, including previous VP shunt insertions or coming for revision or reinsertion. Physical examination with special emphasis on cardiac, respiratory, neurological, and airway examination. Level of consciousness should be assessed and documented. This is very important, especially if the child is lethargic or disoriented. We must see the improvement only by reducing the ICP. So this has to be documented for all the features of raised ICP. Potential difficult airway and intubation to be assessed and adequate preparations made for that. Standard fasting guidelines are advised. Maintenance of intravenous fluid should be commenced pre-operatively to prevent hypovolemia. Younger infants may require dextrose. You said dextrose containing fluid should be avoided, but smaller infants can go in for hypoglycemia. So you have to check the blood sugar and decide whether you have to add glucose to the IV infusions. Otherwise, as you rightly said, it may be normal saline or ringer lactate. And intraoperative management and challenges of pediatric anesthesia, especially in infants. The problem of difficult bag mask ventilation due to gross enlargement of the head macrocephalus and positioning the baby on the table for intubation. And you must keep the difficult airway card, including video laryngoscope. Okay, that is the addition that you have to remember. Anesthesia of technique is choice is GA with muscle relaxation, and you can keep 2 folded blankets below the body of the child so that the head can be placed on the table in a stable position. And holding the baby's head outside the table and somebody is holding it requires a lot of skill and experience, and trained centers where people routinely do this, they may do that. Otherwise, this technique is the most safest. And secure IV line, give glycopyrrolate followed by propofol and atracurium for induction. Alternatively, you can go for sevoflurane and oxygen. And only provided there is no features of raised ICP, because any volatile anesthetic agent will further increase the ICP by vasodilatation. So if features of ICP raised are not there, then you can go for this. Otherwise, IV induction will be the safest. And after assessing relaxation, laryngoscopy is done and child intubated with a appropriate size uncuffed armored tube. That is the tube that you have to use, because the head will be turned this way and that way. To prevent any kinking and obstruction, you must better preferably use a small size armored tube which should not have any cuff. And laryngoscopy and tracheal intubation sometimes can be done in the lateral position also, with the baby turned entirely right lateral. That may be the easiest position to do. And tunneling of the VP shunt from the brain to the peritoneum is stimulating and requires adequate analgesia. So that time you have to prevent any tachycardia and rising BP. That can be achieved by fentanyl small doses or paracetamol or diclofenac suppository if the child's weight is more than 10 kg. And surgeon may infiltrate the scalp and the tunneling sites with local anesthetic with adrenaline to reduce the blood loss as well as provide analgesia. So these are all the methods of providing analgesia for the tunneling part of the surgery. And surgeon may request Valsalva maneuver after inserting the shunt in the ventricle for identifying any leaks present there. And the monitoring, the basic monitoring like pulse oximeter, ECG, non-invasive blood pressure, capnography. You mentioned about precordial stethoscope. If the surgery is going to be a VP shunt where they have to tunnel through the chest wall, then some surgeons may object to your placing the stethoscope on the left side also, because they may prepare the entire chest and drape it in such a way that there is problem, they can take it onto the other side also. So prevention of hypothermia in small babies by the usual method of warm blankets, IV fluids, and all these things is routine. And normocapnia should be maintained. Do not hyperventilate, and or do not allow hypercarbia to happen. So as much as you take precautions to prevent hypercarbia, measures to maintain normocapnia is also very important. And normal saline or interlactate will be the fluid of choice. And completion of surgery, patient allowed to resume spontaneous respiration, and then you can use the reversal with the neostigmine and glycopyrrolate, and patients trachea extubated after adequate ventilation is established and all the reflexes are fully recovered. So that
Yes,
is
sir.
the important points on this, and you have done a good job by saying all the points correctly. Good.
Thank you.
Will you go to the next one?
Yes, sir.
Who is presenting? Soundarya?
Yes, sir. Myself, sir.
Go ahead.